All right, I'd like to welcome all of you back to our event here at Brookings on the state of accountable care. We've had a chance to hear this morning already from Sean Cavanaugh, a CMS perspective on where accountable care is headed, and a panel of expert researchers on the evidence so far about accountable care. We're now moving into our next panel, which is more of an on-the-ground look, an on-the-ground set of perspectives on big issues for ACOs going forward. So we've talked a lot about the national context. What we want to do now is turn to some of the major challenges on the ground for existing and new ACOs as they implement changes in practice, as they move forward on engaging and activating patients, as they take steps towards a culture change around improving care and focus on value, as you heard in the earlier remarks this morning. In those panels, there was a big emphasis on patient experience and patient engagement, about some of the challenges to that based on both the way that Americans have historically gotten their health care and challenges related to the fee-for-service payment system. On the other hand, patients have been a bit skeptical about being engaged in payment reforms that are in the name of improving quality, but too often end up seeming more focused on reducing cost through reducing access. So this is the set of issues around challenges for ACO success are definitely focused on some of the challenges around effectively working with patients in new ways, in these new kinds of care models. Just briefly, I've highlighted engaging beneficiaries as a key challenge facing accountable care today. Related to this are issues with payment formulas. Paying based on quality and cost is different than paying based on volume and intensity. As you heard earlier, the methods are evolving and may not be as aligned as well as they could be with some of the key goals of better care for patients at a lower cost. We've talked about bearing financial risk. On the one hand, the advantages of moving from shared savings to more of that first dollar ability to redirect resources to improve care and lower costs, but also some of the concerns about skimping or access to care that come along with those kinds of larger shifts. Managing startup costs has definitely been a key issue. We heard about some of the new steps underway to help address those challenges for organizations that especially are smaller and don't have a lot of resources in-house. Better data and performance measures, ways of combining accountable care reforms with other reinforcing payment reforms like medical home changes and other kinds of value-based payment reforms. And then finally, identifying best practices for clinical transformation. This is hard work, as you've heard, and the best step forward for a particular organization depends very much on its market circumstances, its own characteristics, and the best opportunities for improvements with their patient population. All this makes being an ACO a challenging task to undertake, and we've got a panel to discuss some of these key issues related to accountable care organization success going forward. This includes, I'll introduce them now, and then we're going to hear from them. Jennifer Sweeney, the Vice President at the National Partnership for Women and Family, where she works with foundations, federal government leaders, healthcare providers, community-based organizations, consumers, and others to develop and implement strategies for improving the quality, safety, efficiency, and patient and family-centeredness of the healthcare system. Jennifer has extensive experience with multi-stakeholder engagement in processes intended to achieve these goals and a deep knowledge of delivery system models and quality improvement strategies aimed at more patient-centered, high-quality healthcare. Next is Kelly Taylor, the Clinical Director of Quality Improvement for Mercy Clinics in Des Moines. She received her BSN and MSN from the University of Iowa. She's nationally certified in case management with over 15 years of case management and disease management experience. And there in Des Moines, she's getting some, I think, firsthand experience with some of these challenges and opportunities around not only case management and disease management, but engaging patients more effectively in their care. And finally, Maury Menaker, the President and Chief Executive Officer of Hackensack Alliance Accountable Care Organization. Maury's been a member of Forest Healthcare Associates since its inception in 1997, and he's worked there on implementing a comprehensive, multidisciplinary approach to help patients become partners in their own care and wellness, and is very much engaged on the ground in trying to implement some of these ACO reforms. So I'm going to start out, as we did with our last panel, asking our panelists to make some opening or framing comments, and then we'll have a back and forth discussion. Jennifer, I'd like to start with you, please.
Sure. Thanks for having me. I enjoyed this morning's presentations. So I work for the National Partnership for Women and Families. We're here in Washington. We are a consumer organization, and we've been around for more than 40 years, working on healthcare issues, including system delivery reform. And as a consumer organization, we have historically been supportive of new delivery models that have the potential to lower costs, to improve outcomes, and to improve patient experience. So I think from the beginning, we've looked at ACOs as a potential benefit to consumers and to patients. I think, though, like the provider community, from the beginning, we've also had some concerns about ACOs, and you touched on some of them, Mark, in your remarks. I think the two biggest concerns we've had is that this would sort of devolve into just a financial mechanism instead of ACOs taking the opportunity to really transform care clinically. I think the second concern we've had is on the issue of patient engagement. Sometimes when people talk about patient engagement, it sounds like what we're really looking for is patients to be better patients versus looking at an opportunity for healthcare providers and ACO leaders to really partner with patients at multiple levels, and I'll go into that in a minute. So as we look across, I think, today's landscape of ACOs, some of the other speakers on the previous panel talked about the variability. We see variability as well in terms of those two areas. We think some ACOs are really looking at this as an opportunity to transform care clinically. Some are really looking at this as an opportunity to partner with patients versus getting them to be better patients. But my sense is that a lot of ACOs have also sort of shelved those two issues. And I understand that, I think, to some degree. There's a lot of challenges in starting up a new business model, the financing, the measurement, the attribution. But as I look forward into the future, in my mind, representing consumers and patients, this model won't realize its potential without the focus on the clinical transformation and the patient engagement. So I'll just take another couple minutes to talk about the patient engagement piece. I think there's four levels that we see patient engagement. First is at the direct care level in things like shared decision making. Second is at the governance level. And it's interesting to me when I talk about this with ACOs about including beneficiaries on the governing bodies of ACOs as a way to help the ACO understand what it is patients need and want from an ACO. I think I'm seeing a lot of confusion about that and frankly lack of interest, which is concerning to me. The second piece is partnering with beneficiaries and patients at the design level. So we know that some ACOs are doing a really good job of not just surveying patients about their experiences in the ACO, but then they're forming patient and family advisory councils and working with those council members to co-design care that really meets their needs. And then the other level, I would say, is also at the community level. I think in my experience, ACOs, but healthcare providers in general, don't partner with community-based organizations like Meals on Wheels, like the Area Agency on Aging. Those are critical to doing transitions well, among many other things. The last thing I want to speak to is this concept of whether or not patients will stay in an ACO and how we help them understand that they're in an ACO. And one of the things I'm hearing recently is this concept of marketing to patients about an ACO, and I really think that's a misguided approach. I really think we need to take a building awareness and an education approach instead. This isn't a sales pitch. Patients don't need to be sold on ACOs if they're getting that patient-centered care that they need and want, and if they're being partnered with at all 4 of those levels. So I'll stop there. And
Thanks very much, Jennifer. Kelly?
Good morning. My name is Kelly Taylor, and I'm now the Director of Quality and Care Management for the Mercy ACO. So Mercy Clinics has traditionally, for the last 12 years, really worked on care transformation, focused at the primary care level. In February of 2012, we became an ACO, and on 1/1/15 we'll have over 200,000 patients and about 1,800 providers. So we've had rapid growth, and that's one of the big challenges, I think, to really sustaining this. We have been successful as an ACO, surprisingly so. I think one of the things the data puts you on is this roller coaster, because in our interim report, we did not share enough or save enough monies for Medicare. In our final, we did by a lot. And so with that, it kind of was the accumulation of a really good year for us, both in the commercial setting, the governmental setting, and then also in with our own employers, our own employees. So we have a big initiative in working directly with employers now going on as part of this work. I think part of the reason, kind of taking off on your comments, Doctor, about that this is here and it's here to stay, I think one of the reasons we were successful is we've kind of been saying that my leader, Dr. Dave Swiskowski, who many of you probably know, has said that for 10 years. We've been planning and working towards this for 10 years. And I would just add to it that for those of you that are in 100% fee-for-service world, like we are in Iowa, you don't have to wait. You can do it now, and you can make it work in a fee-for-service world as well. 10 years ago, we did some fairly inexpensive things in terms of implementing disease registries, which are a heck of a lot less expensive than EMRs, and you can get an immediate return on investment with them. And we embedded health coaches in our primary care clinics. And in a fee-for-service world, that more than paid for itself. The way I didn't have to have a growth strategy for health coaches, because once the providers realized that this was good care, they could be successful and pay for performance, and they made a little money on that, in a fee-for-service world. And now this same group of wonderful nurses are leading us into the value world. So the same things that they've been doing all the time, working with patients, focusing on quality, working with them on the issues of medication adherence, of self-management support, finding out from them what's important to them, what do they want out of their health care, and helping the rest of the care team then implement those importances and desires has really been, I think, what has made us successful, and I think is going to take us a long way into the future as well.
Thanks, Kelly. Maury?
Thanks for inviting me today. A little bit of background. I've been a practicing internist for about 30 years, and am also the Director of Population Health for Hackensack University Health Network. In that role, I initiated and was assisted by the hospital in developing our ACO. We were in the first group in 2012 for the MSSP program. We looked at it a little bit differently. Our philosophy was we were going to use this as a clinical laboratory. We were jumping into the value-based reimbursement scheme. And so we decided to limit to primary care physicians, to mandate patient-centered medical homes for all of our primary care offices, that we bore the cost of all of the training for the primary care, for the patient-centered medical homes. We mandated electronic medical records, and we purchased a relatively strong population health electronic health system, which the EMRs fed data into. This was all upfront monies that the hospital, surprisingly enough, was willing to invest in this organization. We started with a little over 12,000 MSSP patients, with a little over 50 physicians, and I'm happy to say we saved in excess of $10 million on those 12,000 patients. Now, I also agree that this model is not the model for everyone, and that there are many models out there. The end result is what counts, and we all want to get to the same point, and clearly our paths will all be different. We chose some, what I guess we consider to be innovative projects, demonstration projects, which help fuel our success. Number one is we invested heavily into nurse navigators. We embedded them in each of the practices. Therefore, they were there to see the patients during their visits, to develop a relationship with the patients that the physicians may not have had time to develop, to call the patients on a regular basis, especially the high-risk patients, and to intervene when necessary as the first line of defense when one of the patients wasn't sure which medication to take, or should they go to the emergency room, et cetera, et cetera. We were able to cut down our readmission rate dramatically. We were able to cut down our emergency room rate dramatically. The only thing that went up in our database was primary care visits. And once again, not necessarily perfection, but I think as a clinical study, it was shown to be effective. And once again, the reimbursement and the savings bears out that case. We also initiated some relatively interesting demonstration projects. We identified our congestive heart failure patients who were having problems with frequent readmissions. We did something very simple. We put scales in their house that automatically sent their weights directly to the doctor's electronic medical records. Not a very expensive proposition. As soon as it was greater than a 1 pound change in each of these patients, they got a phone call to find out what had changed and whether or not they were being non-compliant with either medication or diet, or what changes had occurred. And in patients who routinely would have 4 or 5 hospital admissions in a year, we were able to keep them out of the hospital by intervening at that level, rather than waiting for the patient to identify that they were in extremis, and then the doctor would say, go to the hospital. And we also started a demonstration project with electronic tablets for these elderly patients, pre-programmed with their medications as a medication calendar. So the tablet would give a ring when the patient was required to take their medication. The patient was required to press the button on the tablet that they took their medication. Once again, directly connected to the physician's electronic medical record, so we could monitor compliance on patients that were taking multiple medications on basically a daily level, not waiting for claims data to come back from CMS. We also initiated a program where anytime any of our patients, the ACO attested patients, would arrive at any hospital facility, inpatient, outpatient, emergency room, urgent care, an automatic notification went to the nurse navigator. So they became aware that the patient was entering the system. So if a patient shows up at midnight on Sunday in the emergency room, that nurse and the emergency room doctor doesn't have access to the patient's medical history, which is on the EMR that doesn't connect to the hospital, the nurse navigator can contact the emergency room, hopefully know the patient, or has access at home to the electronic medical record, and sort of navigate that patient through the system, or contact a physician to intervene. These were small demonstration projects we did with a few hundred patients that once they became successful, the hospital network said, let's roll this out entirely. One other thing that we did, which was hugely successful, was that every ACO patient, upon discharge from the hospital, received all of their medications prior to discharge. We have an outpatient pharmacy as well as an inpatient pharmacy at our hospital. Patient is given all the bottles of medication, instructions, told to go home, throw out every pill that they have in their cabinet, start with the new medication, see their doctor in 48 hours. We believe that this had a major effect on limiting readmissions based upon confusion, patients not filling their new prescriptions, patient not knowing to take the new medicine, the old medicine. And we've rolled that out to our entire hospital, which is 750 beds, after we've shown the benefit through the ACO. So it's sort of the partnership that the ACO has with the organization and trying small demonstration projects on a local level and then rolling them out to our patient network in northern New Jersey.
Great, and it sounds like that's continuing to move forward. Both of you actually, sounds like you've had fairly positive experiences with accountable care efforts so far. I'd like to connect that back to some of the comments earlier today in Jennifer's opening remarks. As we discussed earlier, the evidence does show some mixed results, especially when it comes to what people might characterize as true care transformation. And Jennifer, I know you expressed concern about ACOs just being a financial model and not really being the facilitator of getting to truly better patient-centered care. There are some organizations, though, that seem to be moving down that road, and I think we've got a couple of examples here with us this morning. Just to push on your comments a bit more, how can we best support real changes in care delivery, real systematic changes in how patients are part of these potentially beneficial care systems, and separate that out from the organizations that may just be putting a toe in or not really getting it yet?
Well, I think it goes back to the 4 levels I talked about earlier, with really partnering with patients and beneficiaries at those 4 levels. So a couple more examples. We've seen where some ACOs have actually gone and done home visits with their higher cost patients to understand the barriers that they're experiencing at home, whether that's to fill medications or to get to appointments. I think that's really key. That's really getting at that patient-centered care that patients need and want. I think going back to what we talked about earlier with sort of helping patients understand the benefits of an ACO, and I know this is a little bit more complicated in the Medicare space, but I think there's a lot of documentation you can send to patients, a welcome packet, a frequently asked questions document. But the ACOs who we think are doing the best job are the ones who assign care coordinators and case managers to have actual conversations with patients about what the ACO is, what the benefits are for them, what care will look like for them in this ACO. And that's taking it that step further than just sending home a piece of paper. I mean, we all have too much paper in our lives. I think we need to have more conversations in healthcare. I think also it's all the things that we know patients care about. It's materials written from a health literacy perspective. It's starting discharge planning at admission. It's really connecting patients with the services in their community that they're going to need to rely on once they've left the ACO. So, those are just some of the examples that we're seeing that ACOs, who are really looking at doing a patient-centered job of this, are spearheading.
Now, the evidence base is starting to get better on what kinds of interventions can be undertaken feasibly by ACOs to get that kind of progress with patient engagement. But, from your comments and Kelly and Maury, your comments as well, I mean, this sounds like hard work. There are a lot of things that could be changed for the better. You've got limited time and resources, and more, even though your organization, I guess, Hackensack essentially fronted the funds necessary to try out these specific reforms and expand the ones that work. That makes a lot of sense as a model, but it does suggest that this is this is going to take some time. There are going to be some failures and bumps in the road along the way. Are there steps, either through better evidence sharing or other policy steps that could accelerate that could make the work that you're doing or trying to do go more quickly, maybe happen at a faster pace?
I think that you hit the nail on the head. And that is, we once again started with a small group, basically a clinical laboratory. The question is, where's the benefit to jump into the pool rather than just sticking your toe into the pool? Hospital organizations, very large physician organizations, are dependent upon the fee-for-service dollar right now to pay their bills right now. And there needs to be enough of a carrot at the end of the road to make organizations willing to sort of hit that tipping point and say, we're going to jump in whole hog on value-based. Now, for example, there are certain sticks that CMS is using, such as, the decreasing reimbursement or the penalty for not hitting certain quality metrics for hospitals, but the carrot at the end isn't there. And I think we've already had discussions about that, how from a standpoint of the shared savings program, there's not enough benefit on the back end to really make a concerted effort to drive everyone into a value-based system. And I'm not sure how we're going to get to that tipping point, but I'm not sure it's even going to be an ACO. It's going to be something, whether it's the bundle payment program that we're doing, the ACO program that we're doing, Medicare Advantage. We talked about that. Medicare Advantage has a fixed benchmark that you're working against. If you're going to sit there and say, I can either put my patient in Medicare Advantage or put them in the MSSP, where am I going to get more bang for my buck? I don't know what the answer is, but it most likely is going to be Medicare Advantage today. We're waiting to see what Medicare comes out with the new regulations. And so I think that idea has to pervade a lot of the decision-making here in Washington, because the idea is great. We got to move in this direction, but the devil's in the details.
Kelly, anything you'd like to add about how to make more progress faster?
I don't know that I have the answers, but I can certainly tell you that's the world we're living in right now. Having 2 feet in both worlds is very stressful as an ACO. Having had success in it, I think has helped us leverage at least getting in the room and getting to the meetings and talking with people more about it. But it is very difficult. And the fact that it took us till now, when we started in July of 2012 in MSSP, to get to this point. In the meantime, we've had to cut some staff. We've had to level set. We keep talking and we keep pushing forward. And I think that's just kind of the culture and the philosophy that we have had, at least in the quality department, for a physician setting, to always think that, if I'm doing whatever is best for my patient, then I'm doing what's best for me and for our system. And so that's just kind of been the consistent message for a decade. And I think that really makes a big difference, and it certainly gives us reason to keep moving forward. But again, I would say, that this isn't something that you have to wait for to do. If you're in a fee-for-service world, you can start to learn how to do these things and have a positive business case for doing that. So I guess I'm more focused on that than I am. I'll let other people come up with the answers.
Yeah, you definitely seem like a glass half full kind of person. Go ahead, Jennifer.
So one of the things that I'm not seeing with ACOs is a collaboration typically between consumer organizations and ACOs. And I think it's because you all are, ACOs are doing a lot of work right now, and that makes sense. But, consumer groups have expertise when it comes to communicating with patients and families. And my organization in particular has expertise around performance measurement and redesign from a patient-centered perspective. So I think one of the messages I would share is that we're open to working with ACOs to figure out some of these tough problems and to lend a hand where we might be useful.
And you're starting to get some experience in actually working with ACOs on some of these issues. You want to comment on that at all?
Well, we've worked. One, we've done a lot in the policy arena around patient-centered criteria, and then also we have a coalition where we comment on anything that comes out of CMS. But we've also worked with some of the pioneers and others to help them do two things. One, find beneficiaries to engage in their governing bodies and then ensure that those beneficiaries engage effectively. But also, we've helped some of the ACOs build patient and family advisory councils that they can then collaboratively design care to really truly meet the needs of patients and families.
Very interesting. I'd like to ask, for those of you in the audience, any comments or questions for the panelists. Start up here in the front.
Thank you. Very interesting. I'm Dave Rabinowitz, and the whole issue of healthcare, and especially the Affordable Care Act, has been heavily politicized. And I'm wondering if you're feeling any of the influence of this politics on your patients, especially their acceptability of ACO, or whether they're even interested.
From a Central Iowa perspective, I have to really admit that we have not done marketing of the ACO to our patients. We just try to provide them, good care and high quality care. So we haven't really gotten into that perspective. But I think that for us, we haven't really seen pushback from our patients at all. There's always a few patients that don't want their information shared and that type of thing. But really, the patients that I talk to, they're just focused on getting good care and very much appreciate the efforts. In our advisory groups, this is what we hear. And I would love if we could do satisfaction surveys only on those patients that are worked with by our health coaches, because it's always just, a great relationship, and they really feel, they feel, I would say, like it's about time that they were taken into the picture. Most patients want to be part of what's going on in their life, and I think it's a big reason why we've had issues with low medication adherence or low quality outcomes. The patient is really the missing piece in this.
Kelly, you are living in one of the definitive political battleground states this
Yes.
year, and
Yes.
It sounds like that hasn't really had a direct impact on, for all the controversy around the Affordable Care Act, it hasn't really had a direct impact on the steps that you're taking and the reforms that you're implementing. With some...
I would say that initially the pushback was more from the physicians and other folks in the healthcare in our organization that, didn't really think this was going to stick, was just another project that, Kelly was working on type thing, and others, not just me, of course. But, it is now to the point where I think most of the leadership in our healthcare system really does believe that, this is where things are going. And the nice thing is that being part of a Catholic institution, this fits right with our mission and our values. So now finally, we can talk the talk in terms of mission and values as well.
Maury, you've got a pretty well-known governor and a pretty blue Republican governor in a pretty blue state, but New Jersey has actually been taking some, I think, fairly bipartisan steps towards accountable care and its Medicaid program and the like. What's your experience been with the politics of this?
Well, interestingly enough, I think it's working the other way around, in that as the data came out from CMS showing the successes of certain ACOs, the politicians tended to gravitate towards those organizations to sort of show their interest in the healthcare debate. And it's given us an opportunity to educate our elected officials to the problems and to what we thought would be some potential solutions. So I think that the publicity is a good thing because it's putting it on the front page as opposed to deals being made in the back door and those of us who are actually the providers of care having to deal with decisions that were made without anybody's input.
Other questions in the back here?
Thank you so much. This has really been very interesting. I'm Jan Heinrich. I'm with CMMI, CMS. You all mentioned some very interesting approaches that are focused more on team delivery of care. And my question is, how are you paying for it? So we heard about the nurse navigators. You have health coaches. We're bringing the patient in as part of the team. In the prior panel, we talked about community health workers. And is there an effort to really document how we're using our workforce differently? But really important, how are you paying for it?
I'll start with that. And basically, our hospital network is fronting the cost, as they would for any other new program. Now, the question becomes, how do you determine whether or not there's appropriate profit on the other side of the ledger? I mean, clearly there's benefit. The question becomes, can you show that it's worthwhile in the long term? The problem is that there are very few hospital organizations that run a cost-based healthcare accounting system. A physician's office, a physician organization can tell you where every dollar is spent because every dollar is valuable. If you walk into pretty much any hospital in the United States and ask them what it costs to perform a gallbladder surgery because you want to pay cash plus 20%, nobody will be able to tell you. They'll tell you what they charge, but they won't be able to tell you the cost. So my argument to the administrators were, this program is going to be successful and you have to, let us run with it. Now, what we did as an offset, because of course the bean counters didn't just take my word for it, was that we involved our employee health plan and we created a management structure for our employee health plan. So there was cost savings on that side, as well as the bundle payment program. The bundle payment program, which was initiated by the hospital, required an infrastructure for management. We actually are participating in more bundles than any other hospital in the country. And so therefore, I said to them, I'll also do the clinical management of that as well. So the short answer is, this is being privately funded by our institution. The long answer is, I think in the long run, there's an awful lot of benefit to the hospital, and even just the PR that they've received from us, saving money in the MSSP program is money well spent.
Kelly, any thoughts on this topic?
Kind of the same thing. Our hospital has made the initial investment in our ACO, and we were projected to have losses for a couple of years. We were really honest about that. Didn't quite turn out that way. We're having some good success. One of the things we've done in the past is partnered with other people. We've aggressively gone after grants. We just got a grant from CMMI to spread health coaches and disease registries throughout all of rural Iowa in our critical access hospitals and rural primary care networks. So, we try a lot to try and find different things like that then can help us build the case. That coupled with, I think, in our market, knowing our competitor was jumping right in was a big reason, of course, to do it, as was talked about earlier today. And then again, just kind of going back to mission, you know, this is really what our board of directors, this is how they directed us. They absolutely jumped in with 2 feet and have supported it ever since. And I think in the long run, it will be. I mean, again, it goes back to if you're doing the right thing for patients, you're doing the right thing for yourself, whether that's at an individual physician level or at a, you know, statewide ACO level.
Let me ask if you all feel like the quantitative business case is getting clearer and better for these kinds of reforms. I mean, I get, and we hear this a lot around the country, especially organizations that are committed to this goal of better patient experience and better more person-focused care and hopefully getting savings at the same time, are just going ahead with what they think are the best opportunities to do that, and they're either funding it themselves, or if they can get a CMMI grant or a foundation grant, they're taking those steps. But that by itself is not really a sustainable long-term business model. And you heard Dr. McWilliams talking earlier about a kind of conceptual approach to think about for specific areas of care, you know, what the implications for net revenues would be of different kinds of payment reform models. That's hard to calculate across the board, and not only that, as you pointed out, hospitals and other healthcare organizations just aren't set up to calculate cost versus new revenues in this way because they haven't been paid this way. But is it getting better? Are you finding it easier to make the business case? You have better data that you're actually able to bring now compared to several years ago, or is it more still in the realm of, well, you know, we've been doing this for a few years now, and so far it's turned out okay, so let's just keep doing what we're doing. Is it getting more systematic?
Well, I'll tell you from our perspective, it's a multi-level answer. Number one is we can't keep doing business the same way we're doing it. That's clear. Number two is if we're successful, and I'm not talking about us, I'm talking about the healthcare system is successful, there are going to be less hospitalizations and more than likely less hospitals. And so hospitals are going to have to think about their business and their business model in a different way. So a hospital like mine, which was willing to make that investment, was basically looking and saying, how are we going to be able to change our business model? Is this a direction that's going to make us successful in the future? And I can't speak for administration, but so far they've been very supportive of every efforts that we've made, not necessarily just with the ACO, but in population health as a whole, changing the way that we provide care. Quick example, I requested a computer program for appropriateness documentation for radiology procedures in the hospital. As we all know, anybody on the outside that's not a Medicare patient needs to get an authorization for a significantly expensive diagnostic test. The result is doctors admit patients to the hospital and do every diagnostic test they could possibly think of while they're in the hospital, regardless of diagnosis. We just purchased a program which sits on our EMR that basically blocks orders of anything that's not indicated based upon the American College of Radiology. Now, this is not something that is going to be an upfront win for the hospital, but they see it clearly as a long-term gain to them. And I see it as a benefit because it's going to change physician practice patterns and therefore is going to bring doctors more in line with population health thinking.
Thanks. We have time for one more question back here. We want everybody online to get the benefit as well, so hang on just a second.
Hi, I'm Teresa O'Keefe. I'm CEO of Mind Body Count, and we've created a consumer health score. So I'm very interested, and Kelly, I thought you said that you work with employer populations, because a lot of what I'm hearing in my orientation is employer population health, is things that seem to be working are already happening in the employer-sponsored healthcare. And so I'm interested in the differences, and I've already kind of played some out in my head, but are you also considering incentives for your populations, or have you got to thinking that far? Yeah,
actually, our hospital system was really our first test case to kind of prove this point. And so we've worked really closely with them. And there are patient incentives that have been built in to work with health coaches on lifestyle changes, to work on self-management support and, those types of things. And we've learned from it. It hasn't been perfect. The first year, all you had to do was have 3 sessions with the coach and you got the benefit. And that was a HR designed thing. And then we were able to come in and say, you know what, it's an ongoing relationship. And so they've kind of spread it out so that, you get the incentive, but you maintain that relationship with your medical home. And so, I think there's lots of opportunities that way. And I think you're right, there's already a lot of things that are working. And I think adding care management, kind of as an overlay to that is probably what has led to the success that we've had. We've decreased hospitalizations, we've decreased ancillary usage, all those things with healthcare workers who traditionally are high utilizers. So, I think it's a combination, and again, just another idea of partnering with people. What are other people doing? Leveraging that and working together and having that same consistent, similar message. It's really led to lots of employer groups within Central Iowa coming to us and saying, what can you do with us? What can we do with you?
Jennifer, with employers concerned about the cost of health care and the quality of the coverage that their employees are getting, as well as with the health of their employees, I expect you all have seen some examples where employers can work to support these same models of more effective patient, person, family engagement and care.
Yeah, so we also co-chair the Consumer Purchaser Alliance at the National Partnership. And, I think what I thought was interesting with what you said, Kelly, is that there was an initial uptake, but then without sort of creating that relationship, it wasn't going to work. And I think that's our concern as a consumer organization is we don't want to just give people gift cards and just say, okay, great, everything's taken care of. That's really not, that's a quick fix. It will not be sustained over time. We want to change the way clinicians and patients partner together to get the results we all want in healthcare. So it's really about that relationship and understanding what it is patients need and want, and then working collaboratively with them to design it.
Great, thanks. And I think this point about no quick fixes is illustrated by the goal of some fundamental changes in how patients work with their healthcare providers in achieving care transformation is a good point to end this panel on, illustrating that this is hard work, but clearly some opportunities to make progress in improving care, lowering costs, and especially by thinking outside of the traditional approaches to healthcare. As you all continue to work through this, I'd like to give you a round of applause for the great presentations on this panel. Thank you very much. All right.